Welcome to our series on primary prevention of coronary artery disease. Today we'll be discussing the use of aspirin for primary prevention. So our key takeaways for this talk are that we know the changes to the guidelines in the use of aspirin for primary prevention of coronary artery disease, and we've understood the three pivotal trials that led to these changes and recommendations. Looking at the ACC-AHA 2019 guidelines for the use of aspirin in primary prevention, we see that there's a 2B recommendation for low-dose aspirin to be used in primary prevention in select adults ages 40 to 70 years of age who are at a higher risk of ASCVD, but not increased risk of bleeding. Additionally, there's a notice that low-dose aspirin should not be administered on a routine basis for primary prevention patients above the age of 70 years of age. In sum, the recommendation is that aspirin should be used sparingly in the primary prevention setting. Why is that the case? When we look at other society guidelines, this has been the trend over the past several years. In 2012, the American College of Chest Physicians recommended low-dose aspirin for all patients above 50 years of age without symptomatic cardiovascular disease. But by 2016, we began to see that the European Society of Cardiology recommended that antiplatelet therapy was not recommended for individuals without CVD due to an increased risk of major bleeding. Additionally, the United States Preventive Services Task Force has updated their guidelines in a similar direction. While in 2016, there were some groups who were recommended to start low-dose aspirin for the primary prevention of cardiovascular disease or colorectal cancer, namely those who were aged 50 to 59 years of age, an individually tailored decision for those 60 to 69 years of age. In 2022, the updated recommendations state that for those aged 40 to 59 years of age, you should individually tailor that decision if they are at increased ASCVD risk and a low bleed risk. Whereas adults older than age 60 should not be treated with aspirin for primary prevention of cardiovascular disease. So what is aspirin's role in primary prevention? We know that aspirin is effective at preventing atherothrombosis, and in a secondary prevention context, there's clear benefit, particularly for those who've undergone a percutaneous coronary intervention. The studies showing significant benefit in primary prevention, however, were done in advance of the modern era of preventive medications in hypertension, diabetes, and atherosclerosis. However, even prior to recent studies, several studies like the Physicians' Health Study done in 1989 and the Women's Health Study done in 2005 failed to show mortality reduction in primary prevention. So in 2018, three pivotal studies were published: the ARRIVE trial, the ASCEND trial, and the ASPREE trial. These three trials looked at aspirin in the primary prevention context in three different populations. The ARRIVE trial looked at 12,000 individuals who did not have diabetes but did have moderate CVD risk, between 10 to 20% calculated 10-year risk, and they were randomized to aspirin or placebo. They were then evaluated for a composite endpoint, and they found that there was no difference in outcomes in reducing the composite endpoint, but there was a twofold increased risk of bleeding. The ASCEND trial looked at individuals with diabetes but without known atherosclerotic cardiovascular disease, once again randomized to aspirin or placebo. A composite outcome of serious vascular events, including MI, stroke or TIA, and death from a vascular cause, did show a reduction in the primary endpoint with an absolute risk reduction of about 1.1%, but this was counterbalanced by an increased risk of major bleeding with an absolute risk increase of 0.9%. And the ASPREE trial looked at 19,000 elderly patients, those above age 70 years of age, and randomized them to aspirin or placebo. The outcome in this case was again a composite endpoint of death, dementia, or persistent physical disability, with secondary endpoints evaluated for major hemorrhage and cardiovascular disease, with a median follow-up of 4.7 years. Once again, aspirin did not achieve any difference in disability-free survival, nor did it significantly lower the rate of cardiovascular disease. However, the consistent finding was this higher rate of major hemorrhage with a hazard ratio of 1.38. So taken in sum, there's an increased risk of bleeding across all three trials. In high-risk patients with diabetes, there was a small absolute benefit, and meta-analyses have since upheld these broad findings. So how can we safely treat patients with aspirin, especially those at higher risk of cardiovascular disease? Well, we have to know the contraindications to aspirin. Hypersensitivity and allergy to aspirin is, of course, a contraindication. Any recent bleeding, particularly I pay attention to intracranial bleeding, intraocular bleeding, serious GI bleeding require transfusion, or recent bleeding in other vulnerable sites, concomitant anticoagulant or antiplatelet use, and severe kidney or liver disease. Additionally, we can augment our clinical gestalt by using risk calculators to estimate benefit. For instance, this one at aspiringuide.com that incorporates many different risk factors and then can identify if a patient is truly at increased risk of cardiovascular disease and low risk of bleeding. So in summary, aspirin should be used sparingly in the primary prevention population. Bleeding risk should be carefully measured against antithrombotic properties of the drug, and risk calculators can help us to make better clinical decisions. Thank you so much for watching, and I hope you found this video educational.